Hi, my name is Dr. Mack Drake. I am a burn trauma critical care surgeon at VCU Health. I'm part of the Evans Haynes Burn Center in Richmond, Virginia. Today we're going to talk about the initial evaluation and management of burn wounds. Thanks for joining us. The objectives of this lecture are simple. First, we will review basic pathophysiology of skin and burn injury. We will discuss general principles of initial evaluation of burn wounds. We'll talk about short and long-term goals of burn wound management, and we will review surgical options for burn wound management. There are four basic things that influence how bad a burn is. The first is the duration of contact. The second is the actual etiology of the burn itself, whether it's a thermal, chemical, flash burn, scald burn. The third is the actual temperature of the offending substance or the object that makes contact with the skin. And the fourth and final is the thickness of the involved skin, which becomes very important when you compare a middle-aged person's skin to that of an infant or to that of someone who's very elderly. Normal skin is an amazing organ. It's the largest organ in the body. It is the primary method that our body has of temperature regulation. It's the primary barrier to infection that we have. It's the primary mode of moisture retention for our entire organism. It's flexible. It's weight-bearing. It's sensitive. It's a metabolic organ. It helps with the processing of vitamin D gathered from sunlight. This is just a simple cross-sectional representation of our skin. And as you can see here, this graphic just denotes the classic degrees, if you will, of burn injury, with the superficial burns impacting both the epidermis and just a small bit of the dermis itself. Second degree burns can be broken down into two different thicknesses. Sometimes these are called dermal burns because they involve primarily the dermis of the skin. So we have the superficial partial thickness burns, then we have the deep partial thickness burns. The difference with those deep partial thickness burns is that they behave more like a full thickness burn because they impact or they nearly destroy the reticular dermis, the very bottom layer of dermis that constitutes the majority of its structure. Full thickness burns are relatively self-explanatory. Full thickness burns go through all the different layers of the skin, all the way into the fat, sometimes beneath, and that's a full thickness burn. It's very characteristic if you are not familiar with its appearance clinically. And then fourth degree burns take that one step further, all the way through all the layers of the skin, through the subcutaneous tissue and fat beneath, and into the underlying tissue that's either the muscle, bone, etc. This is a classic representation of a superficial burn. This is a young child who perhaps was just out in the sun too long or was in some hot water. You can see that there's a lot of erythema. It's red. It can feel hot to the touch, but there really is no significant amount of blistering, although it is very painful. And that's a superficial, or sometimes commonly called a. Go back to the previous slide. The surface area of these burns is dramatically increased by the removal of the blisters and the devitalized tissue. So it's important to go back behind after you've done your non-excisional debridement, your initial debridement, and make sure that you have an accurate assessment of the size of the burn pertaining to total body surface and your good skin that we've already discussed. So patients lose moisture, they lose the ability to regulate temperature, they lose the primary barrier to infection that our body has, and they're relatively insensate if you have a thick burn or a deep burn. In any burn wound, we clinically can examine the different zones of injury. The point of the burn wound that received the most amount of injury because it had the hottest substance that contacted it for the longest amount of time is the zone of coagulation. This tissue is typically irretrievably, irreversibly damaged. So this tissue is going to have to be either surgically or or in some other fashion managed, it isn't going to heal no matter what you do to it, really, on a basic level. The exact opposite part of that in the burn wound is this outer zone of hyperemia. There's a vasodilatation there. Blood is being force fed there from a systemic response. That zone of injury is typically viable, at least initially in the resuscitation. That injury typically does not necessarily convert as the wound matures and as the resuscitation progresses. That zone of injury is typically recoverable. The intermediate zone here between those two zones is the zone of ischemia, and the zone of ischemia is the target of the majority of our burn resuscitations. That zone in a large total body surface area burn can constitute a relatively high proportion of that burn. So this is the target of our resuscitations and of all of our very aggressive wound care and avoidance of infection and so forth. So the zone of ischemia really is the target of that, and this is how it's represented clinically, visually on a bed. If I could teach you anything today about the care of burn patients, it would be this. It would be that burn patients really are trauma patients first. Many burn patients have suffered hemorrhagic shock or worse in someone's emergency department or at the first stop along their care path because someone failed to recognize that in addition to the burn wounds, they first experienced some kind of a traumatic event leading up to that. So often we'll see this in patients who are dragged out of structure fires. Maybe they have jumped from a window, they have solid organ injury, they have pneumothoraces, they have airway issues, etc. So burn patients are trauma patients first. The trauma stabilization is very important to go down that road first, and then the burn is a secondary issue. I just want to quickly do an overview of how we assess burn wounds, and then we'll move into the actual nuts and bolts of the management. So we talk about burn wounds by body size, and we get a total body surface estimate on every patient who has a burn wound. There are two ways to do that. The first way is the rule of nines, which is commonly taught, and it's widely available in most resources and, of course, online. It just breaks down different areas of the body into proportionate distributions using denominators and using monifers of the number 9. Obviously, that ratio is different in infants and children than it is in adults due to differences in ratios between surface area of the torso and their head and so forth. Now, I find if someone has a burn that doesn't necessarily conform to one of these very specific distributions, it's often easier to use this. This is the rule of palms. This is using the patient's own palm, the size of their palm, digits included, and making that estimate as 1% of their total body surface area. So you just visually take the patient's palm and put it all over their wounds, and you can also get a relatively accurate estimation of their total body surface area burns from that method also. That method is especially helpful that I've found when dealing with patchy burns from something such as a grease burn, etc. During both of these estimates, we do not include superficial burns. So it can be red, but if it is not blistered, we do not include that in our body surface area estimation. After we get that body surface area estimation, I like to classify burns into 3 general groups. These groups just help me to classify the burns. They help with management. They help with talking to different providers about the burns. They help with disposition. Just as a general grading scale, I would consider a mild burn to generally be less than 5% total body surface area. A moderate burn I would consider to be somewhere between 5 and 15% total body surface area, and a severe burn to be greater than 15% total body surface area. You've already discussed in this lecture series what a burn resuscitation entails and what it looks like. So I want to talk to you just a little bit about the tail end of the burn resuscitation after everything is improving from that, and how care of the wounds then really becomes important. So after the resuscitation, after the injury, it typically takes 3 to 4 days until the capillary leak seals and the resuscitation ends, and then you start to focus on the actual management of the wounds themselves more than perhaps before. Burn shock may still happen, but it should be subsiding. This is a point at which the patient perhaps is the most vulnerable to infection. So great lengths must be taken to defend against infection. And one of the things that is paramount is a good cleansing of the wound every day and attention to topical antimicrobials, attention to early recognition of wound infection. Additionally, nutritional depletion comes into play very important early on in the patient's course. And at this point, when you're making decisions about wounds, when wounds are still evolving, nutrition is more important than ever. Environmental support is additionally important here. Patients with large body surface area burns will be difficult to keep humid and to keep warm, so it's important to recognize that. Primary goals of inpatient burn care are pretty straightforward. First, we really aggressively treat inhalation injury once diagnosed, and you all have already heard that that may increase your resuscitation requirements significantly. Defending against infection is a recurring theme. And then the thing that becomes very important in this lecture is optimizing wound healing. Obviously, if you think about it, more shallow burns heal more readily than do deeper burns. Deeper burns often require some sort of an operative treatment. In the back of our minds, and sometimes in the front of our minds in the short-term outcome, we are thinking about a patient's outcomes in terms of cosmesis and in terms of function. So even though many burns may heal on their own without some kind of a surgical intervention, we always are having to consider whether cosmesis is going to be more poor if we let that heal on their own, or whether the function is going to be the same one way or the other. Early excision of dead and burned skin as soon as the capillary leak is sealed, or even sooner, is the only thing that really has changed burn outcomes as far as survival rates in the last 50 years. We maintain an overriding goal of coverage or closure of all wounds by approximately 3 weeks into a hospital course. And the reason behind that is that the rates of infection, rates of poor cosmesis, poor functional outcomes, etc., really increase if wounds are left open past that point. We also try to prevent hypertrophic scarring, formation of contractures through all of these things that we've already talked about. It's really important that early physical therapy and rehabilitation, occupational therapy come into play. Splinting is an important part of perioperative care. And like I just mentioned, early excision and grafting is the only thing that really has been shown to decrease mortality of burn patients over the last several decades. An important thing to note is that when we do have a severe burn along with an inhalation injury, we only do early excision and grafting, only consider early excision and grafting when the patient is resuscitated, when they are warm. And then when we do go to the operating room for a burn excision or for any surgical treatment of that burn, we try to limit the anesthesia time. And as a general rule of thumb, we don't really try to excise more than 25% total body surface area during one trip to the operating room. So if I could discuss and if I could impart to you who really are the people who are getting admitted as a result of their burns, this is kind of the comprehensive list. So anyone with third-degree burns, full-thickness burns greater than 3% total body surface area, anyone who has any suspicion for an inhalation injury, anyone who presents to my facility with infected burns, anyone with an electrical burn, and I have a separate lecture on that topic that goes into more detail, anyone with a burn that's resultant to hydrofluoric acid exposure, anytime there's suspicion of child abuse or elder abuse. And the reason for that is that you have to pick up on that very early in someone's life. If that's happening, then the chances of a patient who can't care for themselves, who can't defend themselves, of showing up a second time, if this happens a second time, is low. The outcome was going to be way more in doubt. Anyone with areas that are extremely sensitive, perianal region, buttock burns, genitalia burns, any extremity burn that's near circumferential that I may be concerned about a compartment syndrome developing as a result of the ash scar, as a result of the burn itself, needs to be admitted for monitoring. Anyone with lower extremity burns who wasn't able to feel that injury when it happens because of some kind of a neuropathy, like a diabetic neuropathy, admit those patients to the hospital to undergo a course of wound care. Those wounds are often going to evolve and going to be a lot deeper than initially meet meets the eye. So to summarize those things and to make it very simple, I admit people to the hospital who need a burn surgeon for wound care, who need a burn surgeon for pain control, and I admit anyone who cannot necessarily care for themselves so that we can care for them and allow them to recover and allow injuries to heal. So let's jump into just some basics of care in the emergency center. So in the emergency care center, when a patient comes in with a burn wound, the first thing is going to be a trauma survey. So you're going to go through the whole trauma survey. They're going to get a primary survey, secondary survey. We're going to reassess, make sure the A, B's, and C's of trauma are intact. We're going to establish a reliable IV access. You've already discussed that in a different lecture. We're going to send some basic labs that you would see with most trauma admissions. You might see a difference here. I try to send an ABG, an arterial blood gas, with a carboxyhemoglobin level, and anyone who meets any criteria for a closed space fire, anyone who have any concern whatsoever that may have an inhalation injury, I go ahead and I check those labs. And then in burn patients, I often check a hemoglobin A1C because I want to know what kind of glucose control this person has at baseline. Are they a diabetic? They just aren't diagnosed with it. Are they a diabetic and they just are doing a poor job of glucose control? Because if this is way out of bounds, if this is way elevated, then that may kind of alter my decision making with regards to their wound care, with regards to whether I'm going to conservatively and non-surgically, or whether I'm going to aggressively surgically manage their wound. Additionally, I want to know as much information about the circumstances surrounding the burn injury as possible. This is especially important, as you've already heard, in the inhalation injury scenario. But I want to know everything I can about the circumstances surrounding it. And then most patients need a chest x-ray if they don't need imaging for other traumatic injuries. And then attention can really be turned toward the burn wound and toward the initial debridement and wound care that every patient is going to receive on a presentation to the burn center. The initial debridement is relatively straightforward, but if it's not something you're used to doing and haven't seen before, it sounds different than and more complex than it may actually be. So burns generally should be debrided with warm or room temperature saline, plus some kind of a chlorhexidine solution. Some burn centers use commercially available wound care solutions. Some burn centers use just simple gentle shampoo or wound cleansing substance. J&J baby shampoo is often used. Typically, all that is needed for this is titration of some IV narcotic, maybe in a kid, in a child, even some kind of different mode of administration. Intranasal fentanyl, intranasal Versed sometimes is useful. In an adult, I'll often give some IV Versed, or if I can get some of my colleagues in the emergency care center or anesthesia to provide some moderate sedation for me, we even use a substance like ketamine to provide some dissociative anesthesia just to allow us to get this debridement done and to facilitate the patient's satisfaction with that experience. During this procedure, you're going to want to remove all the loose epidermis. We're going to open and debride all of the blisters that you see. You want to expose those wound beds. You want to get everything nice and clean. It's important to note that I find it particularly helpful to estimate size and depth of burns after this debridement already occurs. So it's really not all that helpful to receive pictures of a wound that still has blisters all over it. You don't know what the depth of that burn wound is going to necessarily be underneath, and you certainly don't know a true good estimate of the total body surface area that's injured. Following this, simply blot the wounds dry. I should mention that this procedure is not necessarily sterile. It's an aseptic procedure. It isn't completely necessary to use sterile gloves, sterile sheets, and so forth. I do wear pretty liberal personal protective equipment. You want to make sure to have eye protection, typically a gown. And then I'm trying to limit exposure of the patient, environmental exposure, trying to keep the surroundings warm, trying to keep the patient covered with a nice warm blanket, not allow them to be exposed and allow their wounds to be open to air for an extended period of time. After the wound care is done, after all of these blisters are debrided, which you can do either with a suture removal kit or a pair of forceps, a pair of pickups. You can use washcloths, anything that's a bit abrasive. And the wound surfaces are dry. You then use antimicrobials and then usually layers of gauze followed by some kind of a secure dressing over the top. Many burn centers use ACE wrap, which is perfectly acceptable over the top after a layer of gauze is placed underneath. Places also use a stretch net, like a stretchy woven gauze, which also is perfectly acceptable. The patient warm is important. These are just some standard things that are used in many burn centers. These are very simple, topical antimicrobials. For facial burns, bacitracin may be used 2 to 3 times a day. Sometimes this is substituted by gentamicin. You can also use ophthalmic formulations of these antimicrobials, especially when you're applying this to facial burns that are around the eyes, around the mouth, around the nose. Cartilaginous areas, nose and ears, especially the deeper burns, should have an antimicrobial applied that will have better penetration of the eschar, better penetration of the cartilage. Sulfamylon is useful for that. It should be applied twice a day. Truncal and extremity burns, probably the most common antimicrobial applied is SSD, which is just an abbreviation for silver sulfadiazine or silvadine. Silvadine may be applied only 1 time a day. Silvadine is notorious for forming a pseudo-exudate that then must be scraped off every day and scrubbed down to a clean, healthy wound bed. Silvadine, by the same token, has a wide action of antimicrobial spectrum. It also is very soothing to patients. It smells clean. It helps with pain when it's applied to the wounds. It's very readily available. It's very cheap. It's easy to send patients home with that. Eye burns or any concern for ophthalmic injury from a burn wound or from a chemical injury should trigger an ophthalmology consult. But in the meantime, I usually try to flush the eyes out with saline and then order an application of an ophthalmic antimicrobial. Typically, that's dosed 3 times a day until told otherwise by your specialist. There are other more complex dressings that may be applied to burn wounds. Most of those dressings uh, are linked to some sort of antimicrobial spectrum by being impregnated with a silver ionic component. One that's commonly available is called Mepilex AG. It's a foam pad that has a bit of a more sticky surface on one side. You apply that to the wound. It can be left in place for several days if it's taken care of properly. At our burn center, we change Mepilex every 1 to 2 days, but the silver component lends antimicrobial spectrum to it. Acticoat is another commonly available silver impregnated gauze that may be applied directly to burn wounds. Also, enzymatic therapy with a material such as collagenase or santal may be applied to burn wounds, followed by a dressing to hold that in place. We apply that to burns that appear to be deeper, like deep partial thickness burns, even some full thickness burns on admission, and for subsequent course of wound care. Enzymatic therapy may actually help to facilitate care of some of that intermediate zone of burn wound injury. It may help prevent some of that from going the wrong direction on into the zone of coagulation and then requiring surgical treatment. So enzymatic therapy is a viable option. As a note, a caveat to all of these things, if your facility that you're seeing a burn patient in is not the definitive level of care, if you are planning on transferring that patient to another facility to deal with the burns, then I highly recommend that you consult with that accepting facility or with the ultimate destination facility regarding what they would specifically like you to do as far as debridement of the burn wounds and then as far as the care of them from there on before the patient leaves your facility. Many burn centers on arrival will take the patient straight to a receiving area and will clean the wounds and will have to take off all of the ointment that you have already put on there so that they can get an accurate assessment of the wound. Often we'll ask that the referring facility simply place a non-stick layer and then a nice clean dry dressing over the top of the burn injury wounds prior to transfer. Basic wound care continued. Every inpatient burn patient, whether they need surgical intervention or not, typically gets once daily wound care. At our facility post-op, after 3 days post-operatively, they typically get wound care every day. And then when they go home, they get that same exact regimen of wound care once a day, and they continue this once they go home. We try to make this repetitive. We try to make it simple as possible. And really the preference is that most of these patients get in the shower. That way, this helps kind of facilitate their cleanliness and their hygiene. It also helps make removal of existing dressings quite a bit easier and simpler once they make it. This is just a graphical look at the burn wound flora. Um, and all I'd like for you to get out of this is within the first week of burn wound injury, uh, it's primarily gram-positive bacteria that you need to worry about. So if it's within a week of injury and wounds are clean once the patient is admitted, if they develop a fever, if you're sending blood cultures, if they've developed some burn erythema or some cellulitis around the injury, then I primarily cover just from gram-positives. Now, as you go beyond a week, then and you get further and further and further incrementally, then you start to encounter gram negatives, more yeast type infections, and then you get to more invasive things over the course of an open wound and a hospitalization and so forth of other fungal infections, mold infections, viral infections, etc. So it's important to consider this timeline just in a relatively general manner as you're caring for wounds. This is another reason that we advocate for closing burn wounds within at least weeks after injury. I wanted to discuss a little bit with you about operative treatment of burn wounds. The mainstay, the gold standard for full thickness and deep partial thickness burns, which left alone would place the patient at risk for infection or would place them at risk for poor cosmesis and poor functional outcome, is to excise those burns. So for the patients to go to the operating room, undergo a tangential excision of that burn, and then undergo coverage ultimately with something like a split thickness skin graft, autograft, by using their own skin to transfer it to the injured portion of their body after the wound bed is appropriate to accept that new graft. So for surgical burn excision, for tangential excision, this is the primary tool that most burn surgeons use. This is a WECK, W-E-C-K blade. It comes in several different depths, and you use that to excise the burn. An alternative to that is a Watson knife, which is on a larger scale. And then one of the newer technologies that we have out there is an excisional dermatome. This device is called the amalgatome device, and it's used to very precisely and more quickly excise burn wounds using an air-powered device, rotary device. This is just a patient who had a burn injury. This patient was involved in a thermal flame burn. You can see he's got white, leathery burn wound. It's nice and clean, but it's a full thickness wound. It extends across the lateral surface of the elbow. Left alone, this is going to heal poorly. It's going to take a long time. It's going to put the patient at risk for infection. He also was a smoker. It's going to potentially jeopardize the ability of him to bend his elbow like he would want. So he underwent tangential excision of the burn. He underwent split thickness skin graft with an autograft from his thigh. This was his initial operative dressing takedown. So the split thickness skin graft was prepared using a mesher, which is a device that we run the skin through to expand it and allow it to be spread throughout the burn wound. And this was the patient in follow-up in clinic just a mere 3 weeks later. So you can see his pigmentation is starting to return to normal. Still a bit hypopigmented. You can see that his arm is nicely bent there. He actually had fantastic range of motion, and there are no open wounds to this side. Everything is completely filled in. The pattern of the mesh is already starting to fade. You can see here that his donor site from his thigh is a bit hyperpigmented. This will fade with time. This is a nice result from split thickness skin graft autograft on what otherwise would have been a very um, uh, serious injury. This is another scenario. This is a patient who experienced a motor vehicle crash, a motorcycle crash. He was pinned down. He had the elements of a lateral compartment syndrome on the lower leg. He also had a very thick, very deep, full thickness burn. This was through all the layers of the skin down into the subcutaneous fat. This wound required a fascial excision, so fascia was the only viable thing. So he underwent dermal replacement as this spanned the ankle, and it was important for him to maintain function in that ankle. So this is a material that's called integradermal regenerative template. It's a material that's got a silicone covering on the outside that I've placed many staples into to keep it from shear injury. it's clear, and then the bottom layer has a growth matrix with several growth factors in there. It also has cartilaginous matrix that's primarily derived from both bovine and shark origin. This black gauze on the outside is Acticoat gauze. It's a silver impregnated gauze that I line seams and borders with. And so this guy had dermal replacement for 3 weeks under negative pressure with a wound vac. He then came back and underwent split thickness skin graft, autograft coverage. This is his result after everything is healed. This area was the deepest. This was overlying exposed tendon there, as you can see. So this needs a little moisturization, but overall a pretty good cosmetic result, and the wound's closed. Good function of his ankle after this. So dermal regenerative therapy is one of the things that's in our armamentarium. This is a relatively new technology to the United States. This is a device called RECELL. This device allows you to process small pieces of autologous skin from split thickness skin graft harvest, and this creates an epithelial autograft. It uses a cell suspension technique. You dip this and soak a portion of skin, about a postage stamp size piece of skin, in this well with an enzyme. You bring it out after a period of time. Basically, the enzyme denatures the bonds within the skin segment itself, and then you essentially process it here on this little device. You separate the epithelium from the dermis. So the epithelium, along with its stem cells and keratinocytes, are processed and ultimately placed into a cell suspension in a syringe. This is me in an operating room processing a portion of skin to use on a patient. You can use multiple devices. Ultimately, you get a syringe that allows you to overspray a wound, either primarily if it's appropriate size and appropriate wound bed, or you can overspray a widely meshed autograft within the skin graft to help close it faster and allow you to use less donor skin. Other things that we can get creative with large body surface area burns. This is essentially lab grown skin. This is cultured epithelial autograft, also epithelium. It's grown in the lab in the Northeast. And I appreciate your attention today. I'd be happy to entertain any questions during the live session.